nous parler un peu de votre parcours professionnel et de la manière dont vous avez rejoint CIVCO?
Yes, so I've been with CIVCO for about 8 years. I have about 18 years of medical device background. Previously, I was with a company for 8 years called Aspen Surgical, where I focused on the operating room disposables and consumables business. And before that, I was in the pharmaceutical industry. I came to CIVCO because CIVCO was a small company that was growing at a decent pace, but was going to be accelerating their growth and focused on new products, specifically in the urology market. And they gave opportunities for professional sales reps to grow their career. And so I've been with CIVCO for about 8 years. I started off as a field sales rep in the Philadelphia area, moved into a field sales trainer role. So I was focused on developing new sales reps, joining CIVCO. And then I moved into a corporate accounts role where I focused on contracts with hospitals and IDNs, focusing on bulk purchasing and discounted pricing and expansion of the business. Then I spent 3 years as a sales manager in the U.S. launching Vitro Pro, as well as TP Pivot Pro in the U.S. And then I've been in this international sales role for about 9 months.
Quels sont les principaux facteurs qui favorisent l'adoption de la biopsie transpérinéale en Europe et plus particulièrement en France?
Yeah, so UK and Australia have been at the forefront of transperineal. They've been doing it for more than 10 years, and about 95% of their urologists are doing transperineal. And everyone else is just following. The US is about 50-50 in regards to transrectal versus transperineal, and France and Spain as well as Italy are around the same percentages, around 50% transperineal versus 50% transrectal. The biggest push is the infection risk. We've talked about in the US, and I've heard other physicians talk about, a female can go in for a breast biopsy for breast cancer and have a 0% infection rate. And with men and prostate cancers, their chances of infection are anywhere from 3 to 5%. I talked to a physician in Toronto who moved transperineally, and he said he would do 20 prostate biopsies a week, and at least 5 of those patients would get an infection. And those were serious infections. It was not a fever or a headache. It was patient was becoming septic, and they were going to spend at least a week or a couple days in the ICU. So there's been a big push to move transperineally just because of the infection risk. Most physicians that have moved to transperineal is because they had a patient that became septic, and they just don't believe in giving the option of introducing risk. The other reason is reduction in antibiotic use. Every country is focused on reducing their antibiotic usage, and with transperineal, you don't need to use any antibiotics. Versus transrectal, there's antibiotics being used during the case, before the case, and after the case. And then the third reason is the anterior region of the prostate can be accessed transperineally. The anterior region of the prostate is where 1/5 of all prostate cancer lives, and it's the most aggressive of all prostate cancers. Transrectally, you just can't access that zone. But transperineally, it allows that physician to access that zone easily.
Selon vous, quelles sont les différences les plus importantes entre les approches transpérinéales et transrectales?
Yeah, the biggest differences with TP versus TR is accessing that anterior zone. Transrectally, you just cannot get a good biopsy from a transrectal approach. But with a transperineal approach, it's easily accessible. And again, that's where 20% of all cancers and the most aggressive prostate cancers live. And then the fact that you don't have to use any antibiotics for a transperineal versus a transrectal approach. And the fact that you're not going through the rectum. So there's no chance of getting an infection for that patient. So that's really the biggest differences between transperineal and transrectal.
Quels avantages cliniques ou opérationnels l'approche TP offre-t-elle dans la pratique quotidienne?
Yeah, the clinical and operational advantages are that you can do these in the clinic, you can do them in a surgical suite, you can do them in the hospital. So it's multifaceted where you're not restricted to certain areas of the hospital. If you have a physician that's using a stepper or stabilizer and a grid, they can only do those procedures transperineally in the hospital. Where TP Pivot Pro allows the physician to do those procedures in their clinic or the hospital or the surgery center based on the location that meets the patient's needs and meets the physician's needs.
Comment les praticiens réagissent-ils généralement lorsqu'ils passent de la transrectale à la transpérinéale?
Yeah, their time frame in terms of doing the procedure, because they've been doing transrectally for so long, is going to be a little bit longer with transperineal. But most physicians will tell you after about 5 or 6 cases, maybe 10 cases, their time frame in regards to transperineal versus transrectal is either the same or a little bit quicker with transperineal versus transrectal. The biggest challenges that a physician has going from transrectal to transperineal is delivering the local anesthetic. Local anesthetic isn't used transrectally, and transperineally you're delivering local anesthetic, both superficially and within the prostate. So physician getting used to delivering anesthetic that way is probably the biggest challenge. And then just the nomenclature of the probe, right? So when they're doing transperineal approaches, they're going to move the ultrasound probe in and out of the rectum, versus a transrectal approach, they're actually going to move it left to the right.
Quelles sont les caractéristiques distinctives qui différencient le TP Pivot Pro des autres dispositifs de biopsie transpérinéale disponibles sur le marché?
Yeah, when we developed TP Pivot Pro, we took a lot of physician feedback. There was probably 3 to 4 different iterations of this device, where we would meet with physicians and urologists in the U.S. and get their feedback on the device, and they would make suggestions. The biggest one is that they wanted it to be universal. What we heard from physicians is that they didn't like the fact that they had to buy a different guide based off the OEM or the ultrasound machine. So TP Pivot Pro can fit on any ultrasound probe that's on the market today. The other biggest differentiator is in the name, pivot, right? TP Pivot Pro allows the physician to pivot within the prostate. So what we say is that it allows the physician to have all the control of where the biopsy is going to be taken, versus a tower guide where they have to rely on the angle or the tracking of where the tower guide's going. TP Pivot Pro gives all of the control back to the physician. They dictate where they want to take a biopsy, and it might be in an area of the prostate that's not accessible by other guides.
En quoi le mécanisme de pivot améliore-t-il la précision de la procédure ou l'efficacité du flux de travail?
Yeah, so the pivoting aspect of things allows a physician to get to any part of the prostate. The challenges with precision point or tower guides or steppers and stabilizers is you're fixated on a specific area that guide's giving you. TP Pivot Pro gives the physician the ability to move in and out of the prostate easily without having to make multiple punctures in the patient's skin, and it allows them to target a specific area. If they see a lesion on an MRI that seems abnormal, TP Pivot Pro can pivot to any area of the prostate, including the anterior area or the base or the back of the prostate, where those areas are typically very difficult to get to.
Combien de temps, selon vous, faut-il généralement à un praticien pour se sentir à l'aise avec l'utilisation du TP Pivot Pro?
Every physician's different when it comes to TP Pivot Pro and their competency with it. What I've seen usually is 3 to 5 cases of using the TP Pivot Pro, and then they don't need any other support. Some physicians, like a younger physician or a newer physician that's new to TP versus TR, it might take 7 or 8, but less than 10 is usually the number.
Quel retour avez-vous reçu de la part des praticiens ayant testé plusieurs systèmes?
Yeah, so there's a couple of quotes that we have in our presentations. Dr. Rogers talks about how much easier it is to use and how he's able to access different parts of the prostate that he was never able to access before with different guides. Dr. 𝐏𝐫𝐲 said the same. There's Dr. O'Brien from Minnesota. She's talked about how she's been able to reduce her overall biopsy time by using TP Pivot Pro because she can easily just maneuver the guide or the trocar within the patient's prostate without having to adjust the tower guide or manipulate the probe.